Welcome, everyone. And thank you for being so timely and making that quick transition between the plenary session and our session here today. Welcome to the Health Equity in Diabetes Prevention and Care breakout session. And it's a welcome to not only those of you who I can see now in person, but also those who are joining us online. And I'd like to let folks know online that we will be monitoring the chat. So when we get to the Q&A session at the end, we'll be looking for any questions that you may have in the online chat. So please feel free to do that throughout the course of our presentations today. My name is Bill Mayer, and I am a CMS fellow with the Federal Coordinated Healthcare Office. And it's a pleasure to be with you today. We've been asked to describe ourselves for those who might be visually impaired. And I'm a 67-year-old white male, or as my kids would say, I'm male, I'm pale, and I'm stale. They keep me humble. So we have a very exciting program for you today. We're going to get some introductory remarks from Dr. LaShawn McKeever, who I know you all know from the events of yesterday and today. We're going to have three presentations, one on a culturally tailored approach to support and train promoters and community health workers to engage and enroll Hispanic and Latino individuals with prediabetes in the National Diabetes Prevention Program. A second presentation, advancing healthy outcomes through reduced disparities in diabetes care. And third, CMS development of a diabetes strategy. And we'll be presenting in that order. We're going to be keeping the presentations brief and asking you to hold your questions because we want to be really protective about that Q&A time at the end. We think having a smaller group like this will help to enable a little more give and take. So we look forward to your feedback, comments, and questions at that time. A couple of housekeeping things. First, I wonder if everyone could take a moment to silence your cell phones if you haven't already done so. As I mentioned, please hold your questions for the Q&A segment. And since we're starting late, just as a heads up, I don't know if they mentioned that upstairs, but we're going to still take an hour, if that's okay. If you need to leave earlier, you're welcome to leave earlier, but we'll finish up by 12 o'clock for everyone who may be wondering about that piece of it. So I'm pleased now to ask our speakers to introduce themselves. And I wondered if we could start with Anna. You want to come to the microphone?
Yes. Hi, everyone. It's a pleasure to be here. My name is Ana Consuelo Matiella. I am a Mexican-American woman. I am wearing blue, striped blue pants, very colorful shoes. Anyway, I'm glad to be here. Thank you.
Good morning. I'm Tracy Carver, and I am with Comagine Health. I'm the Senior Director of Community Health and the CDC 1705 Project Director for our cooperative agreement to scale the National Diabetes Prevention Program. And I am a white female wearing a gray suit and a light pink top. Nice to meet you.
Hi, my name is Alicia Daniel. I'm from Northwestern Medicine in Chicago. I am an African-American female with an afro with 17 grays, and I'm wearing a purple dress and black shoes.
Good morning. My name is Christine Rochat. I am a nurse from Northwestern Medicine in Chicago. I'm also the manager of ambulatory care coordination. I am a Filipino-American female with long brown hair, cream-colored top, and a black jacket.
And with no further ado, I'd like to turn the podium over to Dr. McKeever.
Well, good morning, everyone. This is a topic that's near and dear to my heart. I've been able to do work on behalf of people with diabetes for, I guess now about 12 or 13 years. And so I'm really excited today for you to hear about the work that's happening at CMS, which we'll hear later from Dr. Mayer. So Dr. Mayer, thank you for that introduction. Thank you to our panelists who are joining us from across the country. Welcome to our online audience. I'm an African-American female with a black dress, red coat, and a big afro, curly afro. So during the first ever CMS Health Equity Conference, you've heard how CMS is closing the gaps in health within underserved communities. And among the critical gaps we need to close is in prevention and management of diabetes. So new data from our Medicare Current Beneficiary Survey indicates 43% of Black non-Hispanic enrollees and 46% of Hispanic enrollees report having been diagnosed with diabetes, compared to 27% of white non-Hispanic enrollees. The importance of these health disparities was highlighted in the recently released Biden-Harris administration National Strategy on Hunger, Nutrition, and Health, with the commitment to reduce diet-related diseases like diabetes, obesity, and hypertension by 2030. We're excited to report CMS is developing a holistic diabetes strategy to make its commitment a reality. And during this session, we will present the Medicare framework. I will turn this session back over to Dr. Bill Mayer to provide details on this later, and he's also the facilitator. But also, I want to take this time to acknowledge Dr. Mayer's leadership. He's helped to facilitate this effort within CMS, as well as colleagues from across important offices and centers who are doing work in this space. So unfortunately, I won't be able to stay to the end, but I do want to thank you again for coming to this session, and we hope that you enjoy the rest of the conference. Thank you.
Thank you, Dr. McKeever. And now we'll move to our first set of presenters, and I'll turn it over. They're presenters and preventers. Tracy and Anna.
Thank you. All right. So Anna and I are here today to talk with you about a program that we developed in partnership between Comagine Health and Matiea Health Communications, which is Anna's organization, and a number of other partners that we'll share later on a slide, specifically focused on preparing community health workers and promotoras in identifying and engaging people at the right readiness for change in lifestyle change, evidence-based lifestyle change programs. So before Anna shares a bit more about the program itself, we did want to just kind of ground everybody in the problem, which I think is probably not new information for folks in the room. But for the Hispanic and Latino communities, the impact of diabetes and prediabetes has reached crisis proportions. But there's a lot we can be doing, particularly in the kind of in upstream ways to prevent the development of diabetes and to help people manage their diabetes when they do, if they do develop it. So today our program is focused on prediabetes, but we see lots of opportunity to scale this type of a model to also be working with promotoras around engaging people who already have diabetes. So a little bit of background. So Comagine Health is one of 10 CDC grantees for the 1705 Scaling the National Diabetes Prevention Program Cooperative Agreement that actually sunsets in September of this year. And through this work, we have been working in a number of different communities to establish diabetes prevention programs in underserved communities and help them scale. In particular, with this work, we identified the need for a more proactive boots on the ground engagement strategy, particularly in the Hispanic and Latino community. And that's where our partnership with Anna came in. So I am now going, one other thing I wanted to mention before I hand it to Anna is for those who are less familiar, the National Diabetes Prevention Program is a CDC recognized year-long lifestyle change program that is evidence-based and has longitudinal data behind it from a number of different studies, most notably an NIH study that was done years ago. So really the gold standard, and you, if you are in this space at all, you're probably aware Medicare covers it, and more Medicaid, state Medicaid programs have begun coverage. So that is the program we're talking about. And I am going to hand it next to Anna.
Thank you. All right. Okay, well, so let me start a little bit with the program goals. So when we started this, part of the issue or part of the problem that we're trying to solve is that Latinos, Hispanics don't sign up for the national DPP very much, right? We don't have a good record on that. And then when we do sign up, we don't stay. So the attrition levels are, dropout levels are very high. So the program goals that we started with is to empower promotores, promotoras, CHWs, community health workers, to acknowledge their influence and their role in the community and build partnerships and capacity among promotoras, okay? And I say influence is the operative word because promotoras are very influential. They're influencers. Another goal is to increase understanding of the basics among, promotoras, increase the understanding of the basics of prediabetes and diabetes and the stages of change model, which I'm sure you're all familiar with, and how to apply it to recruiting people into these programs, right? Because people have to be ready in order to really benefit, right? So that's stages of change is very important. And then increase understanding of the national DPP curriculum and how to use the toolkit and the resources and inform folks on what it is that they're being recruited for, right? Because it's a long commitment. All right. So what we did is we identified CHWs or promotores. I say promotoras because most of promotores are female, but promotoras, back and forth. Trusted in their communities and provided them with the knowledge and tools to engage and enroll participants in the national DPP. And we did this with a workshop, a 5-hour workshop that we facilitated. So let's see. We held 5 trainings and trained about 63 Spanish-speaking, monolingual Spanish-speaking CHWs in Arizona, New Mexico, Oregon, and Texas. And the preliminary results suggest that we have a strong engagement and retention among these Latino participants, which is good. We aren't really quite finished with the evaluation yet. So, but we have a very creative reimbursement model, which I don't have time to go into, but really ask me about this because it's really important. But questions, because I think it's pretty innovative and pretty important. So one of the goals that we have in training Latinos, Latinas on how to recruit folks into this program is to provide linguistically and culturally appropriate and tailored information, stories. You can notice my title is Chief Storyteller, and stories that are familiar to folks that we're trying to recruit. And for example, in the stages of change model, we have personas and stories about different people from the community that are in different stages. And then of course, I am the fotonovela queen, so I had to include fotonovelas, which we have some free fotonovelas in the back. Please take some, okay? They're back there on that black table. So that's part of how we, enhanced and culturally tailored what we were trying to do. Lessons learned, very, very important. I know I'm like rushing through this, and so please ask me questions because this is the most important part, right? We set out to do this. It's a pilot. We did it in 5 places. The evaluation isn't completely in. So it's like earlier, a colleague said it's a journey. We're still in the journey. We haven't gotten to the destination. CHW recruiters who are part of the community and the culture of the target population are key to success. Nothing about us without us. Really important. Diabetes is a reality in our communities, and a lot of times we have a certain acceptance about diabetes that sometimes becomes a hindrance to making changes related to prevention, right? Everybody's grandmother has diabetes, right? Okay, it's critical to meet community members where they are in the stages of change, okay? So the programs that are flexible and acknowledge the reality of diabetes in the community are more effective, right? The ideal candidate for an NDPP is someone who's already in the contemplative or action stage of the stages of change. That's ideal. We know that, DPP knows that, everybody knows that. But even when we go out there and we meet people who are not in the contemplative stage or action stage. The fact that we're moving the needle is important too. We're moving the needle from pre-contemplation to contemplation. That's really important. Now, another thing is that I am not a community health worker. I'm not a promotora. I'm a health educator. It's really important that when you conduct these trainings, and we're hoping to be able to have a facilitator's guide and a whole program that other people can use in the field. It's very important that at least one of the facilitators in this endeavor be a lifestyle coach that understands the NDPP very, very well, and or a community health worker, right? Because that is where you're going to get the engagement and the authenticity that you're striving for. Another thing that's really important, how are we doing on time? I have time, okay, because another thing that's very important, it's my favorite part, is to infuse the local customs into the delivery of the training and what you're trying to do, provide ample time for practice, role modeling, that kind of thing. But the thing that I want to talk to you about is I have to tell you a little story. So I went to El Paso to conduct this wonderful training with a wonderful co-facilitator and NDPP coach and promotora, who is now a public master's in public health. Thank you very much. But she started off as a community health worker, and now she's an MPH, you know, and running this program. It's like so fantastic what promotoras are capable of doing, right? So, okay. So when we were planning, you know, I'm a curriculum specialist. I planned it. I didn't do it in a vacuum, right? Okay, so you know that, but we don't have time to explain all the process. But anyway, when we were starting to plan for the process, she goes, I said, we need to do something a little fun, right? And get people up and wow. It took place in the middle of nowhere. I hope nobody is offended by that. Near El Paso, Texas, in a mission, in this old ancient mission. And anyway, so she goes, you know what? To get people a little bit like up and at, you know, like exercise, let's do a Zumbita. Well, I don't know how many of you know what a Zumbita is, but a Zumba is a Zumba, one Zumba, right? One Zumba. A Zumbita is a little Zumba. So she wanted to do a Zumbita. I thought, great idea. Let's do a Zumbita. So, but the Zumbita turned into this amazing experience where she hired this Zumba practitioner to come in, and she was wearing like this whole getup, and she brought a boombox and she took us outside to in front of the mission, where outside we proceeded to do a Zumbita, which lasted about 20 minutes. And we were all like in our business clothes. The people from CDC, the observers were like, really weren't allowed to observe, right? Because they needed to be part of the Zumbita. We all did Zumbita. It was Zumbota. It was actually, you know, a big Zumba. And the cutest thing was that there were tourists at the mission, right? Because it's one of the most, you know, wonderful missions of the Southwest, et cetera. There were tourists in front of the mission going into the mission. And when they saw the Zumbita happening, they started doing Zumba. And so everybody was doing Zumba. And just for like, it took, you know, a good 30 minutes. We were running late, but it was so amazing. And it just added so much. And so we really, really encourage people to find those things, right? Find those Zumbitas that you can provide when you're doing your training. You know, if somebody knows how to sing or whatever, right? It's like, I told David, my colleague with Comagin, the next one we did in Nogales, I said, we're going to Nogales, we're hiring mariachis, man, because this is a hard act to follow. So anyway, all right, so that was the lessons learned. The other thing is the role playing, having people actually practice what they're supposed to be doing is really important. Was that you? All
Yes,
right.
thank you,
Yeah, that was
Ana.
fast. Yeah.
You're definitely the more interesting part of this presentation. I have boring stuff. So just briefly, and we're still good on time? Okay, great. So next step. So we developed this training. We did 2 pilots, one in Oregon, one in New Mexico, I think in 2020 into 2021. And then CDC was really excited about what they were seeing, even though our sample size was small. As Ana mentioned, our retention of the people who then enrolled in the DPP was really high. Like in our first 2 cohorts, I think it was around 67 to 69% retention at 6 months. So CDC kind of took notice and said, this is really something we need to pay attention to and dive deeper into. At that point, National Alliance of Hispanic Health and American Diabetes Association signed on to partner with us and CDC and expand the program to Arizona and Texas, as Ana shared. And where we're at now is we're in the process of developing a facilitator's guide to be able to really kind of scale the program and not have it be quite so beholden on us and on Anna to be able to deliver it. And so we and CDC has secured some additional resources to continue to expand this program, initially along the US southern border with Mexico, but I think opportunity in the future to scale further. One other thing I did want to mention in addition to the photo novellas, we did bring a copy of our first version of the toolkit, which I realized I didn't bring up with me. So I'll hand that around during the Q&A if anybody wants to see it. But that is also going through revisions. And then there is a larger evaluation happening right now past just our small, assessment of the data for the first couple of cohorts. Future considerations. I know I'm preaching to the choir here, but I feel like everywhere I go, it's important to really kind of reinforce the message. As Anna indicated, CHWs are really uniquely positioned in these communities to be the bridge between healthcare and community. They have the trust. They are often people that individuals will speak with and be honest with and listen to. And it's really critical that we invest in them as a workforce. And I think trainings like these, when I've talked to other CHW consultants and people kind of in that space, they talk about the importance, even past certification in core competencies, of providing these types of trainings that help CHWs really expand their toolkit of services that they can offer. And it also helps them in their career pathing and goals, as well as hopefully we're giving them the bug of going into healthcare, which I think over time can also help us increase the inclusivity of our clinical workforce. Wanted to just share that more and more states, Medicaid is beginning to cover CHWs in more states. I looked up the latest MACPAC statistic. It looks like 29 out of 48 states reported that they do have a way to reimburse CHWs. So that was really exciting for me to see. Obviously, lots more work to do there. But I think like we're in a snowball moment where, if you can advocate with your legislators and just sort of elevate the need for coverage, both for CHWs as well as the DPP, because we don't yet have coverage in all the states for this important low-cost program, that's a critical opportunity. And I already talked about bridging. All right. And we did just want to take a moment to thank our partners that have been on this journey with us thus far. And we're excited to see this list continue to grow. Thank you.
Thank you, Tracy and Anna. And now I'd like to turn over the podium to Alicia and Christine.
I don't know how we're gonna follow Anna's energy, but
I know.
we're gonna give you all we have, okay?
I'm gonna start out. So our topic today is advancing health outcomes through reduced disparities in diabetes care. Alicia and I both work for Northwestern Medicine, which is an integrated health system located in Illinois. We have 11 hospitals, 200 ambulatory sites, and we care for a diverse population in over 12 rural, suburban, and urban counties. Northwestern's goal is to really optimize health and optimize equity and health outcomes for patients through access to high quality patient care and mitigate disparities. Alicia and I both work for the Collaborative Care and Outreach Department, which facilitates proactive and innovative care by reducing barriers, improving access and efficient use of care while supporting our patients as they move through the care continuum.
So we have 4 key objectives: build pathways and outreach models to ensure equitable outcomes across race, ethnicity, and language, improve access and efficient use of care, provide equity-based support through a multidisciplinary approach, and of course, improve population health. So we're going to take you through a brief overview, detailed overview of the program in its entirety. So first, we're identifying the patients. So patients in under-resourced communities that identify as African-American or Latinx. We're examining patients that have uncontrolled A1Cs of 9 or greater and no A1C reported in the last year. We're also focusing on practices with the highest percentage and volume of at-risk patients. And currently with the practices that we have been serving, the average eligible patient volume ranges between 60 and 200. So now we're going to go over into the outreach portion, which Anna spoke so highly of in terms of community health workers. So at the quarterback of the outreach is the community health worker. Her name is Stephanie Diaz, and she works with reconnecting patients to care, addressing barriers to care by screening for social determinants of health, and direct referral to clinical intervention services such as my partner here, Christine Rochat, and ambulatory care coordination. And in the program in itself, 34% of our patients outreach accepted a combination of clinical interventions and services.
So now I'm going to talk about the diabetes tune-up pathway for the clinical intervention. So this is actually run by my team, the ambulatory care coordinators, which is nurses and social workers who, follow patients and help them with any kind of barriers that they have. So we have some a la carte services. We have direct scheduling to primary care offices, diabetes education. We also provide diabetes or can get them into eye exams. We have a fast track into endocrinology, which we know has a long wait time. And then we also have partners in pharmacy as well as diabetes education that we can turn to. The ambulatory care coordinators also assess for any SDOH needs. And when we see them, we actually refer them to social workers on our team. So some of our outcomes for this system-wide project that we have is that we've had what we see in terms of success is a hemoglobin A1C of less than 7 or a 2 to 3% drop during the time that they are actually with ambulatory care coordination. And once we have control for the glycemic control, we actually hand over the care back to the primary care offices. Typically, the patients are with the ambulatory care team somewhere between 4 and 6 months. And then we also have patient-centered goals that we follow, make sure that they achieve those goals, as well as making sure that they have their own self-health management. Through this pathway, the average patient physician satisfaction is 5 out of 5.
So now I'm going to walk you through some of our program aims. We're hoping to track at least 3,000 patients. We're going to identify those social determinant of health barriers and offer resources to support the patient. We're hoping to reduce those disparities between African-American and Caucasian patients and Latinx patients and other. We're hoping to improve engagement by 40%, with 80% of them showing an improvement in A1Cs, and then reduce unplanned use of care. So those emergency visits, those inpatient admissions that are associated with uncontrolled diabetes, and overall achieve high satisfaction with the patient and clinician. And so just one thing to note additionally is that eligible patients are not limited to a certain payer. It's payer agnostic. So I'm going to take you through, this is a high level view of our workflow, again, quarterbacked by our CHW. She identifies the patient utilizing one of our EPIC reports. She sends a MyChart message to prepare the patient for the outreach conversation. Then she's going to screen for those social determinants of health. So if there's housing, food insecurity, if there's transportation, medication affordability, connection to PCP home, she is providing that type of support and connecting them to the right resources at the right time. She is also informing the patients about the Diabetes Tune-Up Pathway program, where the patient can receive a more robust list of services. And so we all know it's about meeting the patients at the right time. And so if a patient is not ready to go through this robust programming, we offer a la carte services, which include pharmacy, diabetes education, primary care, and connection and direct scheduling to those diabetic eye care exams. Again, if the patient is not ready to accept those a la carte services, we still offer them diabetes education material that we mail directly to their home, and we follow up within 30 days to see if the patient would like to participate in any of the programs. And we've had a pretty good turnaround where some patients initially said no, but then realized, I may need a little extra support, and so they sign up for the program.
So why we're so successful in this program is that it's a multidisciplinary team approach. Endocrinology, social work, ambulatory care coordination, obviously our physician partners, as well as diabetes ed. Our clinical pharmacists are key with medication affordability, and then also our pharmacy technicians that kind of help. With this this treatment team, we actually work together. We have such a great partnership with all of these departments, which is why this program is so successful. So here are the pathway, the objectives. And so how patients are identified, there's a number of ways through Alicia's program, but also other diabetic patients. So a BPA, which is a best practice advisory, actually populates for the primary care physician for any type 1 or type 2 diabetic that actually has a hemoglobin A1C of greater than 9. So typically, some patients, it says 2 or more, but some patients only have 1. And so if they have 1, we actually have them have the primary care physician refer to the ambulatory care coordination. And so what happens is that it is actually assigned to a nurse who is very well versed in diabetes ed. And then what they do is they do an initial assessment. At that time, they do an SDOH and a PHQ-9. And so we are obviously addressing any SDOH needs, obviously any pharmacy needs. So our goal, obviously, less hemoglobin of less than 7. Once they hit that mark or a 2 to 3% drop in what their normal A1C is, the care goes back to the primary care office, and then we discharge from the ambulatory care coordination once they have A1C improvement and they meet their goals of patient-centered goals.
So I see that we're almost at time and I don't receive the hook, but I do want to give you a few statistics, okay? So 34% of the patients that have been outreached have accepted a combination of the services that you see listed here. And so that means that so far today, we've served 253 patients, 3 clinics, and 25 clinicians. And with that being said, we have seen a gradual increase from clinic to clinic. So with our first clinic, only 17% of the patients accepted a combination of services. Second clinic, 25% of the patients decided to accept a combination of services. And our third clinic, we had about 39% receive a combination of services. So it's gradually increasing. And that's due to some of the pivots and changes we had to make sure we reach the target population. And so again, so here's a little bit of further statistics in terms of our target population. So 49% of the African-American patients received services. 37% of the Latinx population have accepted and received services. And then in our under-resourced community, 57% of the patients in that were outreached in under-resourced communities accepted and received a combination of services.
Okay. Thanks. So I just wanted to give you some key metrics. They said we're almost at time, so I'll be quick. So this program has been, the data here is from January of 21 till April of 23. We had 829 referrals to the diabetes tuna pathway. We graduated 100 patients and we had a 31% in A1C drop, which is amazing. We actually saw diabetes ed saw 405 patients. Pharmacy helped 167, and we fast tracked 203 to endo, which is huge. And our engagement rate with patients that are in the diabetes tuna pathway is 52%. So obviously it is the engagement rate has gone up quite a bit. And so we are very proud of this work.
Thank you, Alicia and Christine. Now I'd like to turn to the work that's been going on with CMS across the agency to develop a diabetes prevention and management strategy. And I'll see if I can't get to the first slide. Yes. So as Dr. McKeever mentioned, she was the person charged within the agency to lead a cross-agency work group a little over a year ago now to come up with recommendations and a strategy for the prevention and control of diabetes. And we wanted to go through a little bit about the impact of diabetes in the presentation this afternoon or this morning, a little bit of the strategic pillars that were used in coming up with the draft strategy or framework you're going to hear about, the biggest opportunities that we see before us, the logic behind how we are approaching it within our framework, and then some somewhat more specific examples about interventions. And I'll just mention at this point that, as some of you may be aware, we do have to be careful about telegraphing future policy change that or regulatory steps that might be taken. So we might not be quite as specific as you might like, but that's okay. You can ask away and I'll just demur. And then we'll talk about next steps. All right, well, in terms of the impact of diabetes, as I'm sure you're all aware, and as Dr. McKeever mentioned, this is an enormous problem nationally, but particularly among our the beneficiaries that CMS serves. As might have been mentioned earlier, in Medicare alone, we're looking at 2 out of every 3 Medicare eligible or 65 and over enrollees are either pre-diabetic or are diabetic. And we're looking at a continued increase, in fact, expected doubling of the prevalence of diabetes among adults in the US over the time between now and 2050. So a very big problem and one that's continuing to grow. We have 18 million enrollees in Medicare who report ever having been diagnosed with diabetes. You heard about the disparities that exist and that our enrollees are reporting. And we have very effective interventions to address prevention and management of diabetes. And we'll talk about some of those specific interventions, but just to give you a couple of examples of these interventions and just how abysmally low the rate of receipt is of these interventions. It's shocking. At least it was certainly to me when I first reviewed these data. Less than 5% of Medicare enrollees who are at risk for diabetes have received diabetes prevention or screening services. 5% of Medicare enrollees with a diagnosis of diabetes have received diabetes self-management training. And only 36% of enrollees with diabetes have met all of the goals for hemoglobin A1C, blood pressure control, cholesterol control, and non-smoking. So tremendous opportunities with interventions that we know are effective. So as we approach this issue of how do we impact and reduce the burden of illness from diabetes among the people we serve, we started with these strategic pillars. And you heard about building upon the commitment of the Biden-Harris administration's Hunger, Nutrition, and Health Conference and the commitment to reduce diet-related diseases. That certainly is one of our strategic pillars. Reducing the burden of illness among all enrollees in Medicare, in Medicaid, and in the marketplace and CHIP. Addressing the full continuum of care from prevention through to the prevention and management of complications, advancing health equity, and then finally starting somewhere with a group of folks where we thought we could have the biggest impact. We elected to start with Medicare. And that was for a couple of reasons. First, because Medicare has such a high prevalence of diabetes. And second, because we have, believe it or not, so much more administrative simplicity within Medicare. It's all relative, right? But we have many more policy levers that we can use and apply nationally within Medicare. But our intent is to start with Medicare and then move to Medicaid and the marketplace. But what we're going to be talking about today is a framework for Medicare. So biggest opportunities. I mentioned that there are evidence-based interventions that we know are very effective when it comes to preventing and managing diabetes. Diabetes screening, as you're well aware, currently we have coverage for fasting plasma glucose, oral glucose tolerance tests for people who are overweight or obese. Currently, we do not have coverage for hemoglobin A1C, which is one of the most frequently used tests for screening for diabetes, as well as for managing diabetes. But critically important, if I'm a physician or if I'm a community health worker and I'm advising a patient on where they should go to be able to better manage their risk of diabetes, I need to know not only what their BMI is and whether they are overweight or obese, but I need to know if they have prediabetes or if they have diabetes, because I would direct them in different ways, which I'll get into in a moment. In terms going on of services that have a benefit, we know from the U.S. Preventive Services Task Force recommendations and the extensive literature behind it, that for obesity, intensive behavioral therapy can be effective in producing moderate weight loss. So that's an opportunity that we have. And yet that is used, at least by claims, by less than 1% of people who are obese. So again, tremendously underutilized evidence-based intervention. Next, Medicare Diabetes Prevention Program. That's been discussed earlier. We know that from the Diabetes Prevention Program study that the Diabetes Prevention Program among people who are 65 and older prevented or delayed 70% of diabetes among the participants in that program. Now, if we had a pill that could achieve that kind of effect, we'd see a lot of ads about it on TV, wouldn't we? So a tremendously effective program. Nationally, the most recent data we have, roughly 5,000 Medicare beneficiaries have taken advantage of that program. So there's obviously another tremendous opportunity for us. Diabetes self-management training. This is an intensive program that is focused on structuring and managing the eating behaviors and being active and monitoring blood glucose, taking medications, all those activities that are necessary in order to prevent complications of diabetes and control diabetes. There we're seeing a mortality reduction for people who are in DSMT of 25%. So tremendous impact again. Comprehensive diabetes care, particularly in primary care, more opportunities to prevent the complications of diabetes. Diabetes is the leading cause of blindness. And by getting annual eye exams, 90% of blindness from diabetes can be prevented. So we have so much opportunity here. We have a logic model that we use to develop our strategy, which begins with policy inputs that we think can drive improved utilization rates and the uptake of services and receipt of services by people who need those services. And that in turn can improve outcomes, whether it's the development of prediabetes, diabetes, or complications of diabetes and death, as well as reducing a total cost of care. So I want to spend a little bit of time now on the framework, the intervention framework, and give you some examples of what it is that we're looking at and in our strategy. And you can see here that it is across the care continuum, as I mentioned earlier, and is intended to address all the strategic pillars that we discussed. Starts with diabetes screening and increasing the uptake of screening for diabetes, particularly among people who are at risk for diabetes. And I won't go through each of these. You can see a number of the programs that we discussed already. I'll mention that one of the things that we didn't talk about, which is control of cost of medications. The cost of medications is a big contributor to what's called cost-related non-adherence to care, as you may well know. And with the Inflation Reduction Act, we now have new tools that can allow us to do a better job of both capping the cost of insulin, as I think you probably have all read about and are aware of, at no more than $35 per month, but also to begin negotiating now with pharmaceutical manufacturers to better control the costs and cost increases of medications related to diabetes. We recognize the work that's been going on that you heard about today in outreach and the critical importance of that work to be able to reach those who are underserved in particular and to try to promote increased use of these prevention and management services. And then also want to mention the importance of data. We know that if we're going to effectively target people who are underserved, people who are in those underserved communities, we need to be able to evaluate how we're doing with those folks. If we want to be able to look at health-related social needs and the need for assistance with those social needs and the application of benefits to help overcome those needs, we have to have data to support that. That's going to be a key part of this framework. And then finally, it's not enough to offer benefits, as we've seen from the use of these services. We have to do more. We have to promote, we have to measure, as I mentioned, and we have to reward the receipt of these services. And we have to do so in a way that is aligned and meaningful for both enrollees and providers and suppliers and health plans. And so big part of what we're looking to do is to have a national campaign that can raise awareness of the importance of diabetes, the risk of diabetes, and prevention and control services for diabetes, but also to have the pieces and parts in place that can enable us to align incentives that would reward folks for what we have talked about is the low utilization, and try to lift that up to where everyone who can benefit from these services is receiving these services. We have a timeline. This is not going to happen overnight, but I wanted to let you know that it will be happening over the next 3 to 4 years and beyond. We'll be starting, as I mentioned, with Medicare and then moving to Medicaid and the marketplace. And with that, I will stop. And I wanted to make sure that we had time for your questions. We have the panel here, very distinguished panel that's been doing very exciting work, who would love to hear your feedback and questions. So please, we'll start with this gentleman here with his hand up. And there'll be a microphone coming around. So if you'll wait for a moment.
Good morning. With respect to your comments around the underutilization for pre-diabetics and diabetics, I'm just curious around the integration of community-based organizations, particularly given the point of underserved population, the trust, the access, and the relationships they have. How is that integrated in your strategy, and any ideas around how you might be able to increase enrollment through those various faith and community-based organizations?
I'd be happy to start, and then I'd like to hear from our other panelists. From the strategy point of view, community-based organizations are critical to, I think, the effectiveness of what we intend to accomplish. We do have, I think, the Medicare Diabetes Prevention Program is a great example of relying on community-based organizations to deliver those services. Community outreach, we've heard examples today about methods for doing community outreach. That needs to be an important part of it. So we understand that what is going to be effective here is going to require that we meet people where they are, that we make these culturally and linguistically tailored interventions that meet the needs of the folks that are underserved. Would anyone like to add to that?
Yeah, thanks. I would just add, and I will also say, because of where we sit in the ecosystem, our work is often to help people operationalize these benefits, that has not yet been an easy thing to do. So like with the Medicare DPP program, however, it does exist that there is a supplier type for community-based organizations to be Medicare DPP suppliers. And there are umbrella hubs that are launching, and CDC actually just funded, they haven't announced who they are yet, but I'm guessing there's going to be 3 to 5 umbrella hubs that will be supporting CBOs who maybe don't have the capacity to do all of that claims on their own. And then there are other umbrella hubs that are already emerging throughout the country through the 1705 work. I also want to mention in lieu of services. So the states that are taking on in lieu of services, again, it's a lot messier in application in terms of how we translate to operations. But the intention of in lieu of services, which is a Medicare promoted offering through Medicaid, like they're telling Medicaid plans, you should offer in lieu of services. The intention is to create an alternative mechanism to reimburse for these types of supports. So lots happening out there. I would just encourage you to reach out for help to your local QIO or other organizations like ours if you're struggling. Do you want me to just
Why don't we just go ahead?
keep going?
Enzo, you wanna-
Hi, I'm Elena. I work at Boston Medical Center, and we're also working on launching a diabetes community-based management program. So this has all been so helpful. And my question is for the Northwestern team. One thing we're trying to balance is how to both have a multidisciplinary team, but also not overwhelm the patients with too many people and too many cooks in the kitchen, and having the right person at the center in a way that is financially sustainable. So does it need to be a clinical person with diabetes education knowledge? Is a CHW, the central person? And linked to that, if you have thoughts on how you have funded these early stages, would love to hear any ideas around that.
So I would say for the multidisciplinary team, it definitely, we actually have our ambulatory care nurses that are kind of the quarterback. And they are very well versed in diabetes education as well as, caring for patients. So having them as the quarterback and really explaining the program. But of course, I think like we've said before, we meet the patient where they're at, right? So if they definitely need to see an endocrinologist and they don't want to at this time, we make it as a patient-centered goal that says, let's revisit this next month. Or if they want diabetes education, a lot of times it does take them about a month or so to really get acclimated to what the plan is. But that's what we do. We outreach the patient each month, and we obviously, give them other educations. We have a couple care plans that we offer them as well to explain their disease process and things that they need. So I think it's really dependent on the patient. Some are very, 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 active with our ambulatory care nurses, and others, we have to kind of chase a little bit. But once we do and we get them and they start seeing results, I mean, obviously, we've had some successes, obviously with the 2 to 3% drop in the A1C. And that's also to say that if for some reason they get to that level and then maybe 6, 9, 12 months down the road, their A1C creeps back up, we re-engage the patient. So it's an ever evolving program for our patients. Well, I work for Northwestern, so it's also grant funded, yes. But, that we have grant funded, but we also have, obviously just, it's a system-wide initiative.
Thank you.
I also had a Northwestern question. Just wondering, as you shared some really great data, and I was wondering, are you all looking at the results of the program by race and ethnicity? So like looking at if you're seeing the improvement by different race or by location, and how that, if at all you're thinking about it that way.
So the short answer is yes. Just as you've seen in some of our data, in terms of the services that are received, we're breaking it down by race and ethnicity. We're hoping that towards the end of the programming, that we're able to break it down a little bit further to see what the results are by race and ethnicity. So yes, is the answer to it. How we're going to go about doing is making sure that we're using Epic reporting tools right now. We're also pulling in patient satisfaction scores as well to see how they felt about the program, what their thoughts were, did they feel it was successful? So I'd be more than happy to share that information once we've collected all that information.
I'm going to transition over to our first Zoom question, and this is directed to Anna. Will the facilitator guide include directions on where you would best include or change to add local customs?
Run that by me again.
Sure. Will the facilitator guide include directions on where you would best include change to add local customs?
Oh, yeah, absolutely. And we have a section. Okay, the facilitator guide that we brought here today is just a draft. So we're working on the one after, because we just conducted these 5 pilots. Yeah, and there really is going to be a specific section there on how to encourage bringing in the local flavor, customs and cultures. Is that what the question was? Yeah,
Yes.
all right.
Hi, can you hear me? Okay.
Louder, please.
Okay, sorry. This question is for you, Dr. Mayer. It seems to me when we talk about rewards for utilization, that process is very provider centric. And so I am wondering if you will think outside the box when it comes to rewarding for utilization of diabetes services.
That's a great question. And the short answer is yes. When we talk about rewards and reinforcement, we're talking about all of the folks who are critical to success, including most definitely enrollees. And there are in Medicare Advantage, as you may be aware, there are provisions for providing rewards to enrollees and beneficiaries. We don't have quite the same process today in fee-for-service Medicare, but we recognize in this strategy the importance of having those rewards and having them aligned with enrollees, with providers at the point of care, with provider organizations and with health plans. And the power of aligning all of that and focusing all of that, we think will be a very important aspect of what it is that we need to do to succeed.
Let me turn it over to our next in-person question.
Good morning, everyone. So this question is regards to the diabetes self-management training. So kind of a 2-part question. First, does CMS have any recommendations or like kind of evidence-based diabetes self-management training that you guys suggest? And then also, do you have any data around, the effectiveness of the self-management training, whether it's coming from like a community health worker or maybe from like more of a nurse or diabetes educator?
Well, I'll take a stab at the beginning answer, and if others who have more firsthand experience in providing diabetes self-management training can join in. There is a process for reimbursement by Part B Medicare for diabetes self-management training, and it is through the CDC that the network of providers of diabetes self-management training that network is certified and maintained. So the CDC, if you go on their website, they have the full set of tools. They have information about how to be certified and what's required. But that is what CMS has delegated in an agreement to CDC to help to manage, to make sure that we have hundreds of suppliers of DSMT that have high fidelity to what has been shown to be effective in diabetes self-management training. And as I mentioned earlier, effective DSMT can reduce mortality among diabetics by 25%. So tremendous opportunity there. I know that's a very brief answer. I'd be happy to answer it more fully offline. Would you like to add to that?
Yeah, I have a quick add because I think it's relevant and might help you. Regarding, I don't have data on the provider type, but I did want to share on the evidence base beyond the accreditation process that was just shared. I don't see where the gal went that asked the question. There you are. Thank you. I wanted to let you know, so the Stanford Self-Management Resource Center Evidence-Based Diabetes Self-Management Program, if you're looking for a canned curriculum that can be taught by peer leaders and CHWs, that program has been accepted as, is acceptable as the group education component of accredited program. And a number of our partners have found that that's a nice place to bring in more peer leaders and CHWs to deliver the group education component. So I would definitely encourage you to look at that. CMS, under the 11th scope of work a few years ago now, had also piloted Project Dolce and Deep. I have not seen those programs kind of have the uptake. And so, I don't know, I know there were questions around some of the evidence base on Deep, but if you're looking for programs that are even more culturally tailored than the SMRC model, I would encourage you to look up Project Dolce and Deep as well and see if they're still around. Happy to connect you as well if you need help with that.
One last question, and then we will adjourn.
Yeah, hi, my name is Carrie Howard and I work for Stratus Health and primarily work on a project that is CMS funded specifically to IHS hospitals, and of which Comagine Health is the prime contractor. And this question actually is mostly for you, Tracy and Anna, specific to your facilitator guide. Maybe some folks here know that Native Americans have the highest rate of diabetes and are the most disparate by population. So wondering if your facilitator guide is specific to the Hispanic population, or if in general it's how you adapt that to other communities. And if it's not general, are there plans to adapt that for some of these other populations that are highly disparate?
Sure, I'm not sure that I heard her.
So I can repeat the question, and Anna.
right.
So right now, and you can correct me if I'm wrong,
Mhm.
but our facilitator's guide is specific to the Hispanic Latino community.
Yes.
In terms of expanding or adapting, and we do work with tribes through PATH, which sounds like you're plugged into, and then through the DPP work that we've been doing as well. We do have an interest in expanding the program to be tailored for AIAN populations. To be candid, we haven't found the funding yet. So that's part of my job is to help find the resources to do these things, but definitely an intention that we have. And Anna, anything you want to add about that?
Yeah, so this specific pilot program is designed for Latin American, Mexican American communities, right? That's what it's designed for. The process is applicable across cultures, but the specific information is, in my opinion, not. So it's again going back to nothing about us without us. So in order for this process to be applied to different communities, be it Native American or African American, what I would recommend as a multicultural health communications person is to work with that community, understand the needs of that community, work with local partners with that community, right? I don't think you can retrofit it. I don't think so. Yeah, I would not recommend that you retrofit it at all. The guide is in Spanish and English. Everything is in Spanish and English. But all the examples have to do with, the local flavor and the local input that we got from those communities that we worked with. So yeah, does that make sense? Yeah.
Well, how about a round of applause for our presenters here? Thank you all for taking the time out of your day to be here today and for all of your input today. I did not mention in my presentation that the CMS strategy in particular, that framework did include the lived experience of people with diabetes through listening sessions that we've held. We also would welcome your feedback and input, and we'll be continuing to talk with stakeholders in the future. So please give us your thoughts. Thank you again and enjoy the rest of the conference.
Yeah. Thank you so much.
Thank you.